الفضل كله يرجع طبعا اللي احنا فيه ده الدكتوره عائشه دكتور الدكتور. It's my pleasure ان انا موجوده النهارده وان انا ابتدي الاميونولوجي سيشن. التوك النهارده عن new warning signs of inborn errors of immunity and what's beyond the infections. Inborn errors of immunity are a wide number of conditions featured by severe immune response, and their classification is in a continuous update. Recent advances in the clinical comprehension of inborn errors of immunity, together with the expansion of the genetic background, allow better knowledge of the non-infectious manifestations. New diseases with the predominant immune dysregulation phenotype, which will be the first sign in 10% of the patients in absence of significant infections, have been identified, leading to an extension of the spectrum of immune deficiency diseases. Like the target of this talk in EHNA, early suspicion by all general practitioners, with pediatricians and other medical specialties. We need to draw the attention to non-infectious manifestations with a good clinical reasoning. عشان early referral لينا أو clinical immunologist for early diagnosis to reduce the morbidity and mortality of this group of diseases. طيب احنا عندنا around 430 genetic defects for the inborn errors of immunity. 300 اللي هم يعني كانوا already known predominant هم infection and recurrent infections phenotype. الجديد بقى around 129 genetic defects هم مش جديد بس هم دول اللي ابتدوا يبقوا recognized lately. Mainly a presentation immune dysregulation even in the absence of infections. All warning signs اللي كلنا كنا عارفينها recurrent infections with severe infections with unusual pathogens. New warning signs with red flags هي autoimmune cytopenias, lymphoproliferation, cancer susceptibility, autoimmune endocrinopathies, early inflammatory bowel disease, systemic autoimmunity, and vasculitis. Currently, it's recommended that the inborn errors of immunity to be considered in patients with autoimmune manifestations of early onset and refractory to conventional treatment, severe and difficult to control allergic conditions, recurrent or persistent inflammatory processes with or without fever, malignant diseases with early onset and or unusual presentations. لو عندنا كمان family history of familial cancer syndromes. There's a lot of factors for the development of autoimmunity in PID patients. The intrinsic factors اللي هي genetic factors, the PID genetic mutations with HLA phenotype. The extrinsic factors, it's mainly triggered by environmental factors with infections with dysbiosis, where this might have caused an impaired immune tolerance. The possible mechanisms of immune dysregulation in the PID patients حاجات كتير قوي ممكن يبقى فيه defects في T with T cell development and tolerance, the T cell signal transduction, the T regulatory cells, the FOXP3 with CTLA4 with LRBA mutations, the control of apoptosis by patients presenting with autoimmune lymphoproliferative syndrome, the ALPS with ALPS-like, the inflammatory bowel disease, and hyperinflammation, susceptibility to HLH with repeated hyperperiodic fever syndromes, defects in complement pathways with interferon pathways, or part of the main immunological diseases via tumor necrosis factor pathways. The genetic basis of infections versus immunity. These genetic defects كتير قوي في كل presentations. Repeated infections ممكن يبقى في part منها autoimmunity. يعني في atypical forms of severe combined immune deficiency that present autoimmune hemolytic anemia beside the infections. الويسكت ألبرت syndrome مع الأكزيما والثرومبوسايتوبينيا ممكن يبقى في autoimmune hemolytic anemia وسايتوبينيas. الهايبر IgM repeated sinopulmonary infections وبرضه autoimmune cytopenias. Other genetic part بقى المين presentation هي الautoimmunity. CBID common variable immune deficiency, برضه combined immune deficiency زي ال CTLA4 وال LRBA وال NF-kappa B. المين presentations هي autoimmunity. الIPEX والIPEX-like, الALPS والALPS-like. الpresentations autoimmune cytopenias, endocrinopathies, enteropathies دول المين presentations. بس ممكن يبقى معايا حاجات ثانية arthritis, vasculitis, SLE, alopecia, vitiligo. يعني دي من الساينز اللي احنا we have to look for it. طيب أول حاجة الاميون deficiency في الهيماتولوجي يونت، وده أكتر حاجات احنا بنشوفها. presentations of autoimmune cytopenias could be a first presentation of inborn errors of immunity. طبعا أكتر حاجة autoimmune hemolytic anemia. Our patients are at 120-fold high risk of developing autoimmune cytopenias. بتشك امتى؟ لو انا عندي unusual age, early presentation, chronic course, out of practice cytopenia, not responding to conventional treatment. لازم look for a history of the infections in patients. The family history is very important. Family history of infection, of immune dysregulation, of autoimmunity. لازم look for extended family members. Multiple cytopenias is a red sign, يعني from the red warning signs ان احنا ممكن يبقى عندنا underlying immunological disorder. Lymphoproliferation مهمة قوي, بس هو لازم أول حاجة exclude malignancy. It could be part of common variable immune deficiency or autoimmune lymphoproliferative syndrome. They're at high risk of developing lymphoid malignancies, وطبعا ما ننساش إن احنا test for E.U.P lymphoproliferative disorders. Cancer susceptibility could be first presenting signs. في patients كتير قوي first presentation malignancy. Patients with ataxia, telangiectasia, nitrogen breaker syndrome. والGATA2 deficiency could be lymphoid or extra lymphoid. ما ننساش family history is very important. في familial cancer syndromes we have to look for it. أو family history of immune dysregulation. طيب يعني a quick example كده, male patient جانا هو عنده 6 سنين, born to consanguineous parents. First presentation هو كان عنده enteropathy since infancy, يعني كان diagnosed إن هو severe. At the age of 3 years ابتدى يجيله repeated attacks of hemolytic anemia, وكان diagnosed إن هو autoimmune hemolytic anemia. وبعد كده ابتدى يجيله attacks of thrombocytopenia. He received the treatment steroid, cyclosporin, IVIG, والcytopenias get more or less controlled. At 5 years ابتدى يجيله hepatosplenomegaly lymphoproliferation, وat the age of 7 years جاله extensive psoriasis, we're not responding خالص for treatment all over the body. بعد كده عن 7 سنين ابتدى يجيله infections. الاميون بروفايل بتاعه الاميونوجلوبولينز كلها كانت قليله. CD19 البي سيلز كانت almost absent. والتي regulatory cells كانت zero. ده التوين سبب ان انا عندي immune dysregulatory disorder. ده كان شكل الاكستنسيف psoriasis اللي البيشنت كان عنده. البيشنت ده diagnosed with disease of immune dysregulation. طيب في endocrinology unit, as a general rule, multiple autoimmune endocrinopathies of early onset plus the family history of endocrine disorders and autoimmunity should represent a warning sign. احنا بنشوف الاير mutations اللي بتpresent chronic mucocutaneous candidiasis, ممكن يبقى معاها endocrinopathies وenteropathy. برضه بنشوف الايتكس اللي هو immune polyendocrinopathy وenteropathy. بالهوكس B3 mutations برضه type 1 diabetes, autoimmune thyroiditis, eczema, enteropathy. والايتكس like presentation زي CTLA4 والLRDA مع autoimmunity, enteropathy, lymphoproliferation, وممكن ما يبقاش فيه infections, even الimmunoglobulins ممكن تبقى normal. GIT طبعا a wide range of inborn errors of immunity, including a common variable immune deficiency with chronic granulomatous disease with T-regulatory cell disorders. In early onset within the first month of life deserves significant attention. But it's a severe form of inflammatory bowel disease or severe enteropathy, مش diarrhea بسيطة يعني. وممكن يبقى معانا extra intestinal manifestations. We have to look for a family history. In monogenic causes of IBD ممكن تبقى 10 to 20% of the pediatric IBD patients. عندنا الانترلوكين 10 والويسكت والCGT والcombined immune deficiency والCVID ممكن يبقى برضه early presentation, early onset IBD. There could be برضه hepatic involvement زي autoimmune hepatitis, genetic defects with a susceptibility to HLH زي XLP1 and 2 ممكن يبقى فيه elevated transaminases. Another family, 2 siblings. Our patient عنده 13 سنة. كل presentation بتاعته chronic diarrhea since infancy. We can diagnose IBD with a partial response to treatment. هو 13 سنة, severe failure to thrive, stunted underweight, وكل مشكلته enteropathy. جبنا أخوه الأكبر 15 سنة, severely stunted underweight, مشكلته كلها كانت ابتدت enteropathy. وبعدين كل شوية بيجيله recurrent attacks of hospitalization, وكان diagnosed إن هو عنده severe form of asthma. الولد كان بيجيله كل شوية attacks of arthritis وarthralgia وjoint swelling. كل ده ما كانش فيه برضه يعني evident infections. آخر CT test بتاع older brother باين إن فيه pulmonary fibrosis. الاميون بروفايل بتاع اول طفل الاميونوجلوبولينز بتاعته كانت قليله، لكن التي سيلز والبي سيلز والريسنت تايمينج ايميجرنتس كانت قليله، يعني they're almost absent. الاولدر براذر الاميونوجلوبولينز كلها كانت قليله، وبرده السي دي 4 والسي دي 19 التي والبي سيلز والريسنت تايمينج ايميجرنتس were very low. مدام برضو احنا كله immune dysregulation they were diagnosed ان انا عندي disease of immune dysregulation. mainly presentation كلها حاجات autoimmune مفيش infections خالص. الاميونوديفيشنسي في الالرجي يونت طبعا الاكزيما الاكستنسيف اكزيما في الهايبر اي جي اي والويسكد والايبكس والايبكس لايت and we should not forget the newborn erythroderma في الأومان syndrome. آخر حاجة في الروماتولوجي يونت among the manifestations in sarcoidosis like phenotype. Early onset systemic autoimmunity, بالذات ال SLE والvasculitis could be a warning signs for inborn errors of immunity. The clinical presentation could be misleading, positive family history, multiple autoimmune disorders, lymphoproliferation, repeated attacks of hyperinflammation represent important elements in the identification of high-risk patients. طبعا البرزنتيشنز ممكن تبقى granulomatous disease مع lymphoproliferation، ممكن الpulmonary involvement تبقى in the form of granulomatous lymphocytic interstitial lung disease أو sarcoidosis like clinical picture could be associated مع chronic granulomatous disease أو common variable immune deficiency أو hypomorphic drag mutations. early onset connective tissue disease SLE ممكن يبقى فيه defects في الcomplement في interferon pathways أو في RAS associated leukoproliferative disorder. برضه early onset systemic vasculitis should ring a bell. Autoinflammation it's يعني new trend دلوقتي overlapping مع diseases of immune deficiency ده هيبقى discussed في cases later on. في targeted therapies كتير قوي انا بس يعني I mentioned الحاجات اللي موجوده او اللي احنا يعني ممكن نكون بنستعملها. الريتوكسيماب ده anti CD20 targeting the B cells للاوتوimmune hemolytic anemia والrefractory cytopenias. السيروليمس اللي هو الانشور inhibitor برضه في الاوتوimmune lymphoproliferative syndrome في الالبس والrefractory cytopenias. الاباتاسات is a T cell modulator برضه ممكن يبقى used في LRBA والCTLA4. الانتي-tumor necrosis factor زي التاكسيماب في common variable immune deficiency. الانتي-interleukin 1 الاناكينرا في CGD والautoinflammatory disorders. في حاجات كتير زي الانتي-interferon gamma والJAK inhibitors يعني ممكن يبقوا The take-home message in the primary immune deficiency disorder is no longer defined by infection cells. Autoimmunity as cytopenias, early onset IBD could be the first clinical sign. Accumulation of multiple autoimmune manifestations with age, family history of immune dysregulation should raise clinical suspicion. Identifying inborn errors of immunity early also represents a great challenge. Treatment of PID patients with autoimmunity is most successful with narrow spectrum immune modulation using biologicals, specifically targeting the immune pathway. Stem cell transplant to be considered in genetically defined refractory cases. وده التيم بتاعنا which I'm very honored and proud to be part of.